Would you like me to share the link to the images? Okay, here you are. Sorry, I'm technically slow this morning.
Me too.
Okay, so the images are there. You can kind of start taking a look at them. They are not technically the best. And then the history, let me just bring the history. And also share the link to the images so you can open them and take a look. Okay, so this is a history. This is a 7-year-old dog with acute abdominal pain and distension, vomiting, depression, and anorexia. I remember this is a quite old case. It was during my residency. Yes, 2011. And I remember the hallmark was the pain. But anyway, take a look at the images. And now in a second, I'm going to share the link. So you can open them on your computer. Copy. Chat. There they go. So you can click on that link, you will be able to open the images. Otherwise, you can look at the images on my screen. There are a bunch of images. I would say probably none of them, and there's thorax and abdomen, probably none of them is just perfect. Like it seems that they got the cranial abdomen and then they got the caudal abdomen. Similarly in the DV is either the cranial or the caudal abdomen. It's like not technically perfect, but I think it's probably okay. Okay, so maybe I move this out of the way. Good. And I don't know if I want to open that and then have this one here. I'm not sure if that is helping. And then I'm not sure which one is better, either this one, that probably is a good one, or this one. I don't know, we can put both probably. So there we go. There's no right lateral projection, it's just left lateral and then VD. Middle-aged dog, abdominal pain, vomiting. Lethargy.
Any history of trauma or anything that we know of, or not?
No, not that I know. Not that no, there wasn't any history of trauma. Move over.
I guess I'll start with the obvious. There seems to be an increased opacity in the kind of mid to cranial region of the left abdomen.
Yeah. I agree with that.
Sorry?
Agree with that, sorry.
And it also seems, I would say there seems to be a mass effect there in some ways, in that there's loss of serosal detail, but if there is a mass effect, it seems to be, the reason I'm thinking that is because the small intestinal gas patterns seem to be on the laterals, caudally displaced, or displaced to the right, quite laterally. But I guess maybe you could argue that there is just lots of serosal detail in that area, but probably less.
Okay, so it seems that you are going back and forth between two ideas. It seems that on one side is the idea of a mass effect, and the explanation for that is that there is displacement, and then, but you are uncertain if that is the case or if there is fluid. I would assume that because you are saying kind of one or the other means fluid without mass effect. Is that correct? So you're wondering if, Okay.
I think probably mass effect more than anything, especially because it's so rounded, that area. Like it does seem like almost like circumscribed, like you can see that round area. I guess the other thing as well, I mean, unless it's like a fluid-filled area, like a sectioned off area, like the retroperitoneum, but I think it's probably unlikely just because I've never seen that before.
So I think what you are saying is perfect, and it's awesome to have the thinking aloud process. So I probably would invite others to comment on that, because you seem to be, and perfectly fine, you are wondering about two options. Another way, and again, this is all thinking aloud, but it's an exercise in how we think. It would be this idea of the hypothesis testing, or I was just recently reading a book and they call this not hypothesis testing, they call it like natural selection. It's kind of playing the game of natural selection with ideas. Makes sense? So you present ideas, it's the same concept, but so you present ideas and then you see what is the fittest idea. Makes sense? That can explain everything. And the one that can explain only a little is obviously less fit compared to the other one. And then therefore the fittest wins. I love this idea, and basically is what we do. So here you have, like, it seems to be two competing ideas. I would probably add that they are not competing ideas. You may have both. But so can we try to find what is the best fit in terms of which idea out of these two, mass effect or free fluid, can explain what we see best?
I think the mass effect, because the margins, like, it seems very well delineated.
Okay, so your underlying idea is that that would not be present if there is fluid.
Yeah.
So that's a feature that is supporting the idea of a mass effect, and is against, makes sense, doesn't fit the idea of free fluid. I know what you mean. If we go like pure into what we are talking about, is I'm not sure I agree. And I tell you, where is the point of, and this is very thin, and it's just maybe semantics. We are all the time talking about mass effect. I don't know why no one really called this a mass. So if you're calling about mass effect, the difference in between mass effect and mass is that our inability to identify the mass. Makes sense? Otherwise, so ideally, when you see a mass, you call it a mass. And that's the easy way. Why is that we invented the term mass effect? Why is that we are not brave enough to call it a mass? And in that situation is because we don't see the borders. Makes sense? Because we see the consequence of a mass, but we don't see the actual borders. So that is kind of a defensive attitude, is to say, well, I don't see the mass, but there is something acting like a mass. So if we go by that definition, then Catherine, your argument doesn't really fit, makes sense, because you are using our ability to see the borders to defend the fluid, when the mass effect, actually, we don't see the borders in any way. But again, this is semantic. If we use the word, instead of saying mass effect, we use the word mass, then your argument is perfect. Well, if we see contours, then that's a mass. We don't expect to see contours if there is free fluid. Any other
Yeah,
argument?
makes sense.
That explanation that was quite long and complex is clear enough. Any other argument in favor or against, whatever?
On the VD as well, I think I can see in that area that we're questioning, I think I can see the silhouette, or the silhouette of the left kidney, which I imagine probably provides more argument for a mass or a fluid-filled structure that's with the kidney kind of sitting on it, but not within it. So perfect. I assume it's less likely to be surrounded by fluid. because we would efface the kidney.
Yeah, so two situations. And again, perfectly thinking aloud, because just making the connection without explicitly saying why then is kind of poor. What we are doing is perfect. So you see the kidney. How are you going to use that information? Well, if you see the kidney, means a couple of things. First, that the mass is not coming from the kidney. Makes sense? Because otherwise, then you should not be able to see a normal kidney. You should be able to see an abnormal kidney. So if you see the mass and the kidney, means first that it's not coming from the kidney. Second, or at least it has a very weird shape. Makes sense that it can show you the kidney and then a huge mass. And then the other thing that it's telling you is that there's no fluid around the kidney, because it could be the situation where you have the mass and the mass is producing fluid, and then you will not see the kidney, not because the mass is the kidney itself, but because the mass is producing fluid and the fluid sits around the kidney, and then you erase the kidney. Makes sense? So, but based on what you are saying, there are a couple of conclusions. First is that the mass is likely not coming from the kidney. And then I would even add that we can see the kidney in the lateral projection. It seems to be located in the normal position. So it's not only not coming from the kidney because we can see the kidney right, but it's also not displacing the kidney. It seems that the kidney is not bothered by the mass. Makes sense? It's in the normal place, normal shape, normal contours and opacity. All the features are there. And the other conclusion that we can take from that statement is that at least in the retroperitoneum, at least surrounding that left kidney, there is no fluid. Makes sense? So that's the other piece of information that we can get. Anything else?
There's an abnormal amount of gas in the intestines, which suggests probably he's aerophagic, I think, rather than obstructed.
Yep, perfect. So he's, I like the comment. So the comment is the amount of gas. The diameter is okay. So the diameter is the one that is telling us usually if there is an obstruction or not. The diameter is within normal limits. So then we need to be thinking about differentials like aerophagia. So perfectly fine. I think in this case, is the content of the small bowel is giving us a nice, is showing us, is helping identify what it looks like a mass. Coming back to that discussion about the mass and mass effect or everything, I don't think we should have any question or be very hesitant in calling this a mass because it's acting like a mass. So the small bowel, there is no reason why the small bowel is occupying almost the entire abdominal cavity, and then for some reason there's not a single bowel loop sitting here. I hope you can see my arrow. There's nothing sitting here. So I think we have the right to call it mass effect, whatever. But the distribution, so the small bowel is, and this is another point that usually goes kind of unnoticed. We usually pay attention to the small bowel just to judge the small bowel, is it distended or not, whatever. But it's very useful as a telltale for mass effect, makes sense, so things moving around. And I would say that probably every gas-filled structure in the body, trachea, airway, stomach, colon, small bowel, they are beautiful telltales about the positioning, makes sense, because they are easy to identify, and it tells you probably not so much about themselves, but about their neighbors, okay? So in this case, coming back to that discussion, I think there is something there that is not allowing the small bowel to sit in there where it should be. So there is a mass, if you want to call it mass effect, I'm okay with that. I would have no issue calling that a mass. It's acting like a mass, it is spacing the bowel. Then the next point in this discussion is, can we have the situation number 2, which is the mass effect or mass, and then additional free fluid or not? Makes sense? So if we see borders, then we call it a mass. If we don't see borders, we can call it mass effect. And then there are a couple more considerations that we need to make in terms of if there is fluid there or not. Okay. Anything else you want to add? Anything to add to the description?
The mass is kind of in the area you would expect to see the spleen, and I can't see a normal looking spleen, so that would make me suspicious it was a splenic mass.
Okay, very good. So that's the next step. Anytime we make the call about a mass, then the next step is to see, the pattern of displacement. Where is it originating? In which part of the abdomen, or the thorax? It works the same. And then how is that displacing stuff around? So your comment is very good. So it's coming from the left, and it's where the spleen usually sits. The dorsal part of the spleen. I would personally probably add one more thing, and I know that I sound like a broken record about this. Is the stomach? The stomach, is a very good telltale because it's basically telling us a very nice story. So the stomach is not caudally displaced. The stomach is sits in the normal place, and that is basically, if we now start thinking about different structures that could be affected, someone could have argued, well, is it possible that this is coming from the liver? And the answer is, well, it could, but unlikely. And the reason why is because most, not all, but most of the masses coming from the liver are going to have a consequence, are going to displace the stomach caudally. So this is a very good telltale. If you consider that option, probably you should say, well, I can't completely rule it out, but it's unlikely because the stomach sits in the normal place. Makes sense? So again, we are using something easy to identify our knowledge about the anatomy and how things displace depending on where the mass is coming from. So your consideration about the spleen is a very good one. Probably the other thing that I would add is that, well, in this case, someone could be thinking about this, the kidney, the left kidney, and we already mentioned that we can see the left kidney seems to be in the right place, seems to be not displaced, so it's less likely. Any other considerations in terms of structures? Is it which anatomical structure, if it turns very big, could result in this appearance?
What about the pancreas?
Yeah, the pancreas is another good one. I agree. So the pancreas sits, the left lymph on the pancreas sits exactly there. So it's connected to the stomach, connected to the colon. The colon seems to be coming this way. There's a little bit of colon there, here, and it seems to be also displaced somehow. So yeah, very good point. Anything else?
An intestinal mass?
Yeah, that could, I think it's probably less likely, but I don't think we can remove it from the list. I would probably think and then remove the idea of left adrenal mass, because somehow it needs, if it's gonna get that big, it somehow needs to bother the kidney. Makes sense, because they are too close, and somehow needs to, I would expect some degree of displacement.
Mm.
Okay, and then before we go into the, now thinking about what are the different options in terms of disease processes going on there. Anyone, I remember, even though it's more, like it's 10 years since I've seen the case, I still remember that I was very bothered by what I thought was a mismatch between the size of the mass in the VD and then the size and the appearance of the mass with the size and the appearance of the mass of the lateral projection. Like if you give me this, only this projection without the other one, I'm not sure I will call it even a mass effect, probably a little bit here, but it's not as clear. Anyone wants to comment about that? Or anyone wants to offer an explanation?
Is the gas kind of superimposing over it?
Oh, good point. Good point.
Looks like
Good point.
looks like that space is filled in that kind of 2D
Yeah.
plane.
Good point. I think that is actually a very good explanation. So the mass is kind of on one side, there's bowel on the other side, so then they are superimposed. And yeah, perfect. I think that's is a good explanation. But it's somehow slightly unusual. Usually like splenic masses, they sit here and then they give you a very nice, actually, usually it's easier to see them on the lateral projection. So there was something like not perfectly fitting in this case. So options, what are your differentials? Oh, maybe we need to try to, I don't know if you're going to end up in a perfect agreement, but what do we think about the fluid or not fluid? And I think in this scenario, it's kind of important to know if there is fluid or not. So, and that comes back to the discussion: is this a mass effect or a mass, or so? How convinced are we? How likely do we think there's fluid in addition to something looking like a mass?
Personally, the dog looks really lean, so you're going to get poor serosal detail anyway. And you can kind of see the ventral border of the mass on that left lateral. So I'm not strongly convinced there's fluid there myself. But I'm always, every week I get serosal detail wrong, so who knows?
I think I agree with you. I'm pretty sure there is no fluid there. There's a minimal amount. We can still probably hear, there's an increased opacity, but we can still see contours. Probably there is a bit of loss of serosal detail here. So if there is a minimal amount. There's not a massive amount. We can still see the contour of the stomach, the wall of the stomach, the contour of the liver, the contour of this that we are uncertain what it is. I think we can still see the serosal contour of the bowel. So if there is, I think there is a mild amount. Okay. Good. Options, differentials.
I guess you're looking at splenic torsion or a large splenic mass. Because of the possibility of a torsion, it would be ideal to have a look with the ultrasound first to see if there's blood flow.
Very good, very good. I agree with those comments. And I also agree, so I agree with the kind of the consideration. So it could be a mass, and I suppose within mass you include things like a hematoma, primary like a neoplasia, granuloma, whatever, those differentials. That's extremely hard to differentiate, even if we do ultrasound or whatever modality we run. That answer is going to be extremely hard to answer. That question is going to be extremely hard to answer. But on the other side, you are saying, well, but it could be a torsion. And then the solution that you are offering is, well, let's do ultrasound. And in the same way that I'm saying, like, hypothetically, ultrasound or CT or whatever you want is not going to be able to differentiate. Until now, we don't know enough to be able to differentiate like a hematoma from a hemangiosarcoma, or there is the expectation that a torsion should look different compared to the rest. So, and then the modality that is obvious next step, to make that call should be ultrasound. And we are lucky because I have the ultrasound, and this is how it looks. Let me double click. Yes. So anyone willing to?
I think this is a common image in a splenic torsion.
And why?
Because I don't know how to say this in English, like the hyperechoic lines, like striated. I don't know if this word exists or not. Como estriado, como.
It's the star.
Cool. Yeah, so let me see. I think there are two sets because I remember we had two machines, and I remember I did one more than anything trying to solve the case. And then when I realized what we are dealing with, I decided to go and take some better images with another machine, just to keep it as a teaching case. So these are the images. The first thing that I would probably mention in terms of spleen, how it looks here, is that there seems not to be any focal lesion. Makes sense? So there's not like a cavitation, whatever, anechoic, hyperechoic, or hypoechoic, but whatever. There's no masses. There's no focal lesions. It seems to be just enlarged, and I can show you multiple images that they all look the same. Seems enlarged, and then it seems darker. You can call it hypoechoic. You can call it darker, but basically it's diffusely hypoechoic, and the echo texture seems to be more coarse and kind of with that granular. There is a name to that, but I also forgot. Maybe someone remembers. Yes. So then, in this, and then the next thing is that if you put Doppler on the veins, there is no flow. Okay. So if you put all of these features together, and then let me show you the other one, where I'm not sure I put like flow, but basically the spleen looks very hypoechoic. See, there's no mass effect. The echo texture looks coarse, but there's no focal. There are no focal lesions, and there's no fluid around, and there wasn't any flow in the vein. So it has all the features that we need to make a call about a splenic torsion. So this is kind of a very cool teaching case. You know, it's like every feature that we need is there.
Would the history of this case also suggest that that's higher on your list as well, because it hasn't got a lot of fluid to suggest an acute presentation because of bleeding?
I agree. I agree. Yeah. So this, actually, I don't remember the presentation. I just went to the book and copied there, you know, what's the classic presentation of a splenic torsion. So I just wanted to present like a very characteristic case, if you want, in terms of the imaging findings and in terms of the presentation and everything of a splenic torsion. Do you have any questions? And then there are, I can see comments like about surgery and even before going to the ultrasound. And so we can have a discussion about that. Like, I suppose the discussion is when should we stop imaging and then just go in? How much imaging is necessary in a case like this? How much was it worth doing an abdominal ultrasound, or should have gone in just with the images in the radiographic images? I don't know. We can have that discussion. In my eyes, probably if you have the availability of imaging and you have someone that I can run an ultrasound, I think the role of imaging in this case is to be better prepared about what you're going to find, to know if you're going to be able to fix it or not. Makes sense? So can any imaging finding prevent you from going to surgery? Makes sense, because you may already realize that it's something that you cannot. I don't know. I'm thinking there's a mass effect. The option of a mass was still there. What if there are mets in the liver? Makes sense. What if the lymph nodes are superhuge? What if you see seeding of the peritoneum? I don't know. I'm trying to justify in this case. It's not that I think in every case imaging is indicated, but I think in this case, probably when we see something that we are pretty sure is in the spleen, still running an ultrasound. If the means are there and if the availability is there, I think it still works. But I'm happy to listen to options. And of course, I'm not saying that's a bad option. I think that's a very good option. But I guess it depends on the availability of ultrasound in this case, for example, and someone running it.
I totally agree. Like, coming from an emergency perspective, if you put the ultrasound on and it's like looks like a hemangiosarc, you're going to have a very different conversation with an owner going into surgery compared to something that, you know, is potentially fixable, even if you don't find mets. So obviously, like, not everyone's got an ultrasound and things, but I think if you've got it available, you should be getting as much information as you can before going to surgery, people.
And probably, and I wasn't intentional, but probably this is one example why ultrasound may be useful in a situation like this, because it's basically telling you a completely different story. In a sense, this is a torsion. I think with ultrasound we can be pretty sure. So then I think making a call about going into surgery or not, in this case, is different again compared to having a mass where it could be from benign to malignant. So yeah, with this, I'm not like an imaging Nazi. I'm happy to listen and wonder and consider when it's indicated, when we are doing too much and it's unnecessary, and probably taking action is the best way forward. But right, in this case, I think if you have the ultrasound, I'll put it on, and I think it will give you more information and help you make a better call. Any comments?
Well, certainly with regard to blood transfusions too, if you knew whether the dog was likely to need one. I think someone's commented before.
And then, so that is in terms of making sure if there is free fluid or not.
Yes.
Yeah.
I will throw in there as well that it does, as James is saying, it does so much depend on the situation. So if it's late in the day and you're not going to get an ultrasound till tomorrow, I think that's obviously a bigger risk for the patient than going to surgery without an ultrasound. But
I agree.
It's probably just use your judgment, don't you?
Yeah, again, it's all about making a clear-cut rule about, you should always do this. I think it's stupid. It's based on, again, availability. What's your situation? You have it or you don't have that. So yeah, I completely agree. I don't think it's any hard rule in cases like this. Is like, for example, like now, for some reason, I'm remembering the discussion about when to go in a vomiting dog where you think there is an obstruction and how much to wait or not. And I find myself usually in a group of, well, if you have a question, go in, even though I'm doing imaging, but I don't see that as a bad attitude. It's like, well, there's a point where if you don't have the means to go forward in terms of imaging, then there's nothing wrong about going in. And then, if we were wrong, if we are overreacting, it's probably better to overreact early rather than overreact late. So I don't think but again, that balance, that best decision, I think is very individual. It's about the particular patient, the particular place, what facilities do you have, what capabilities do you have. But clear, beautiful case. I remember, to be honest, I think we took radiographs first. I can even check that. And I remember not even thinking about a torsion, to be honest. And then when I put the probe, I said, oh, this is what I remember reading in the book. This is exactly how it should look. So for me, it was a teaching case, and that's why I saved it. And I think it's a nice one.
Hey, Mariano, what makes that kind of speckled look on ultrasound?
Interesting. I don't. I have a theory. I'm not sure if my theory is proven. What it usually happens in a torsion, and I think this is regardless of spleen or whatever, is that there is an obstruction of the venous return, and usually the arterial flow can go somehow because there is more pressure there, and you can overcome that twist, of the vasculature. So if you keep adding, at the end of the day, it's kind of an edema situation. Makes sense? So you keep adding fluid, but you block the venous return. So then there's an accumulation of blood, if you want. And I think those are, if you cut the spleen, you're gonna have like blood oozing from that spleen. It's just because there's that accumulation of fluid. So when there's it's the same thing if there's a torsion of the, a mesenteric torsion of a hernia through the mesentery, and there's or a herniation of a bowel loop through a hernia. And then, so the arterial blood supply can still go, venous return is obstructed. So basically, if you look at that bowel, it's gonna look red and thick, and makes sense. So there's a lot more fluid in their blood that cannot come back.
Cool. And do infarcts kind of look similar, or
Say that again?
infarcts like
Oh, by definition, I was just thinking about that. By definition, this is an infarct, if you want.
Yeah. Okay.
It's
So
not
kind of
an-
similar.
A hemorrhagic infarct. Makes sense. It's not the infarct. You know, you can divide the infarcts in hemorrhagic or arterial or venous. Makes sense. So if you block the arterial supply, then there's no hemorrhagic, unless there's a revascularization. But if you block the venous return and there's still arterial supply, so this is kind of a hemorrhagic infarct. Yeah, I never thought about using that word in a case of a splenic torsion, but I think the mechanism is the same.
Okay. Yeah.
Sorry, I missed the first 5 minutes. What were the classic clinical signs of this that the dog presented with?
The ones that I put in there, yesterday I went to the book and I copied. Let me show them, share with you. So acute abdominal pain and distension, vomiting, depression, and anorexia.
Okay, cool. Thanks.
Yeah,
Mariano, are there breeds predisposed to splenic torsion?
I think so. A large, deep chested. Yeah, I think so. I was reading about that yesterday and I already forgot.
Okay. About the position of the stomach when the spleen has a torsion, then
Yeah.
should we expect because of the vasculature, shouldn't we expect the stomach to be slightly displaced? or
Yeah,
not?
that's a good point because we have the gastrosplenic ligament, and then basically everything that happens, they kind of go together. You know, when there is a GDV, usually the spleen also, actually the dorsal part of the spleen goes ventral, and we talked about that. There is a characteristic appearance of the spleen in cases of gastric torsion. So, but what I was referring is that it's the whole displacement of the stomach. So I think in this case, it's going to be kind of a stretching, if you want, of that ligament. But this is independent for the spleen. The spleen is kind of the one that rotated without affecting the stomach. And if that spleen gets enlarged, then if anything, I think I will have the expectation that it will move or displace the stomach cranially. It will be extremely difficult for that splenic torsion to move the stomach caudally. And that is as far as I want to use that feature. Makes sense? I want to use it, and I always use it. So if there is a mass, and I would say the same thing for the colon, for example, the small bowel. Every time you mention the word mass or mass effect in the stomach, check those structures. Check the stomach, check the small bowel, check the colon. Because there is a clear pattern of displacement of depending in which organ is affected. Liver displaces the stomach caudally. Kidneys usually displace the colon ventrally and the small bowel ventrally. Makes sense because there is a mass coming from dorsal. I don't know. Prostate is going to move the colon dorsally. Makes sense. So there is kind of, and there is a very nice, very simple book that has very nice drawings. I can share with you. So is this one. And if you go into, I think there are general comments about abdominal structures. They have peritoneal cavity, I think it's here, where they just talk about mass effect and they have nice drawings. Yeah, see here. So if the mass is coming from the kidneys, what displacement do you expect, and so on. So and I think Thrall has also very nice drawings about, and basically all the organs that are going to be in that drawing are the ones that you can always see, which are gas filled: colon, stomach, small bowel. And hence, those are the key players in every displacement. and it always works. It works beautifully. Okay. Any other question? Otherwise, I have a little bit of another case. So I don't know if you've seen the connection between last time that we talked about a colonic torsion and today's case, which is another torsion. So there is a link. And then, so if this case is, I don't think you can make the call about this case, but I'll share with you, and we may not finish today, but we can get started and then hold on, because I thought I would be able to find it fast. Okay, here. And if so, let's see how far we can go, and then I can just post it and continue the conversation next time. So lateral projection, left, right. Let me see if there's a better right there. No, another left. Probably the right. This one may be better. I don't know. And then let me bring the beginning. And I think, well, there are a couple of things. These are extremely interesting case and extremely unusual case. That's why I don't have any expectation to get to the right answer. But they are very interesting findings. So we can get started today, and then I'll post this one, and then so you have the time to look carefully at the images, and then we can continue discussion next time if we don't finish. I'm trying to get the best. So again, technically it's not the best, but this is left lateral. This is right lateral. Probably, that's the best combination of images. So almost the same topics that we talked about with the previous case could be used and applied to this case. So I don't think I can share the images right away. It will take me a while. So unfortunately, you need to look at my screen and see if you want to give it a go. Otherwise, I just post it, and then you spend your time. Actually, you can write your report and then come the next time and tell us what you think about this case. It's a fascinating case.
I'm keen to write the report.
Okay, good. We can leave it there, and then we come back. I'll promise I'll do it right away. So then everything is ready for next week, and we talk about this case, which is at the end of the discussion. You will see that there's somehow there's a story, case last week, case this week, and this case. But obviously, I don't want to give it away. I don't want to tell you what's the thing that brings these cases together. But there is a theme going across. Okay, so we leave it there. I'll promise I'll post these ones sometime today. It seems that we are using we are thinking right. All your comments were very good. So we are getting into the mood. Everything that we use today, all the arguments and explanations and everything, use that information to try to tackle this case and see how far we can go. It's very, you will love the answer.
Very cool.
Quick question, Mariano.
Cool.
Just about, you talked about trawl. Is that just the diagnostic radiology? You were talking about the one that had the recommendations for what organs are displaced.
Sorry, I couldn't get that.
We're talking about the textbook. Was it trawl? T-H-R-A-W.
It's trawl, T-H-R-A-L-L.
No, but
Yeah,
this is
Yes.
another one. So
Yeah, it's like the main diagnostic imaging textbook.
yeah, but this
Yeah,
this
that's what I
is
was thinking.
one that is called Handbook of Small Animal Radiology and Ultrasound. It's an interesting book. This one I like, and the way that it's written is, I'll show you. So basically, it's differential diagnosis. So there is a little explanation. So this is how you search. So basically, it's based on features. So let's not go radiographic technique, but so body effacement in the thorax. So that's that's huge, and then they go through that. Tracheal displacement, and then let's go there. So let's see, if you click tracheal displacement, then you have different options. So you say, well, dorsal displacement of the trachea, what could it be? So there is not a lot of explanation about the disease process, but there are kind of a list of differentials, and then there are drawings, and you can continue the story and look for more. There could be a ventral displacement of the trachea. Make sense? And so on. You can go right lateral displacement of the trachea. So it's for thinking, if you can identify in a radiograph the features that you're talking about, but you are short in ideas about how to explain that finding. I love this little book. It's just opening your mind, makes sense, giving you options. These are the options that can explain this finding. And then from there, you keep going. It's very simple. There are no radiographs. They are all drawings. So it's basic. I don't think you can use this book on its own because it's lacking the images, but that's not the objective of the book. The objective of the book is to have an organized way to go deeper into the imaging findings. Makes sense? So now you say the trachea is displaced this way. What are the possible options? Makes sense? So I find it extremely useful. The authors are extremely good. Ruth Dennis, Kirberger, Barr, and Wrigley. So Wrigley was here in Sydney. He passed away, but he's kind of a friend of us, if you want. And these are very well-known people that I think when you go through the book, when you have a lot of experience, of years of experience, I think you can make something complex into something easy or simple. And I think that is not trying to remove complexity, it's trying to, is based on the experience, they have the capacity to bring something complex into something easy to deal with. And I think they managed to get this with that book. And they are not trying to say, this is the most in-depth book of imaging. No, that's not their objective. Their objective is a handbook, easy to deal with, easy to find, easy for you to, in the practice, to go and open your mind about, what are you dealing with? What are the possible options? So I highly recommend this book. Yeah.
Looks good.
Yeah. And I personally use it all the time. Like the classic example is, I don't know, pleural effusion, alveolar pattern in the lung. And, the easy differentials, the one that we see all day long, they come to mind immediately. I don't need to go to the book. But there are those cases where I'm lost. And I said, I can see that finding, but I don't know where it's coming from. I can't put it together. So I open that book and I go through the options. And very easy. And then sometimes I say, oh, actually, now that option is a good option because now makes sense. And for some reason, my brain was not bringing that option to start with. So I use it in that way. Yeah, it's good. Okay.
Awesome. Thanks, Mariano.
See you next week.
Yes.
Thank you.
Thanks, Mariano.
Thanks,
See you next week.
Mariano.
All good.
Thank you.
Thanks.
Bye-bye.
Mariano. Ooh. He's gone.
Okay.
Yeah.
Oh.